Hi, my name is Jay Mathews. I'm an interventional cardiologist out of Bradenton, Florida. I'm the cath lab director at Manatee Memorial Hospital. Today I'm here to talk about a case using sync vision, specifically a circumflex lesion. So this is a 70-year-old gentleman with peripheral arterial disease, diabetes, hypertension, dyslipidemia, and ongoing tobacco abuse. He presented with unstable angina symptoms, and we decided to go ahead and perform cardiac catheterization. In this first image, you can see that the patient has an intermediate severity lesion of the ostial circumflex. Based on this, I wasn't sure exactly where I needed to go ahead with my intervention. So because it was intermediate severity, I decided to interrogate it with instantaneous wave-free ratio using the sync system. The reason why I chose to use the sync package was to perform iFR co-registration. This allows me to interrogate the lesion further and identify whether or not the ostial lesion alone is the contributing factor to the patient's presentation. So you can see here in this image we have an intermediate severity lesion. Next up, we go ahead and perform iFR and perform iFR pullback. So on the iFR, we see that the lesion itself is quite significant at 0.70 with a significant diastolic gradient. However, all this does is tells me about the resting condition distally within this vessel. So I'm more interested in what the lesion is and where the severity is. You can see here the multiple dots in the left main. However, this component is not significant. There is a significant pressure gradient across the ostium, and this is a significant component to the lesion severity. If you look distally, by extending our stent further, we can now almost normalize the iFR. So it allows us to decide our stent length, and I can go with a single stent solution. Extending a little bit further, while it makes the vessel look prettier, does not actually improve the lesion hemodynamics. So at this point, we opted to go ahead and place a shorter stent. In this view, you can see us placing a 33mm stent. After IVUS-guided optimization, we mark the ostium and place the stent. So one could ask, why perform iFR co-registration in this particular case in comparison to traditional iFR? If I had performed iFR only, perhaps I would have only focused on the ostial lesion, and the patient could have still been ischemic, at which point we would have had to place a second stent. By performing iFR co-registration and identifying the second tandem lesion, and then marking where my longer stent would be, it allowed me to get away with a single stent solution. iFR co-registration can be very useful in a number of the different lesion modalities. I find it to be very useful in tandem lesions or left main involvement, where I'm trying to figure out how much does the left main contribute to the overall physiology of the vessel. In these multi-vessel type situations, you can take a patient from a 3-vessel situation to a 2-vessel or even 1-vessel solution, in which case we can get away with single vessel or double vessel PCI and potentially avoid cardiac surgery. iFR co-registration is a very easy modality. It doesn't really add much time onto your case. Simply being able to wire a lesion, perform a pullback, and then go ahead and proceed with intervention is about the time that it takes. So we're talking about adding on a couple minutes to your case overall. Therefore, it actually improves the efficiency of your case because you're able to identify and perform lesion preparation and planning immediately. Sync vision has made performing complex PCI much easier. By simplifying patients from multi-vessel disease down to single or double vessel disease, we're able to optimize our PCI outcomes.